Good morning. You can hear me okay? So I'll start off with our normal format for you, our current numbers. As of this morning, we had 94 total inpatients in our system. There was 1 at Acadia, 6 AR Gould, 1 CA Dean, 54 at Eastern Maine Medical Center, 8 at Inland Hospital, 8 at Maine Coast Hospital, 1 at Mayo Hospital, 13 at Mercy Hospital, and 2 at Sebastian Valley Hospital. In addition to that, we have 28 COVID-19 home care and hospice patients. The 2-week positivity rate is 23.8%, and the 1 week is 25.76%. The continued rise in positivity rates indicates that COVID-19 is more prevalent than ever in our communities and speaks to the need to get vaccinated, boosted, wear a mask in public, stay home if you're sick, and continue all the other healthy behaviors that we've covered on many occasions with you before. We do not have a new inpatient graphic today. The data in the graphic is manually validated for accuracy, and we're working through changes to make the process more efficient. We hope to have a new one to share by the end of the week. Given the recent surge in cases and high hospitalization rates, I know many of you have questions about hospital staffing. Before we address that, I would once again reiterate that the best way people can help our hospitals stay adequately staffed and have capacity to stop the community spread of COVID-19. How can you do that? You've heard it here from me before. Wear a mask when indoors in congregate settings. Where social distancing is not possible, practice good hand hygiene, stay home when you're sick, and if you're not vaccinated yet and eligible to do so, please get vaccinated. If you're not boosted yet and eligible to do so, please get boosted now. Now I'd like to turn over to Matt to tell you how and where you can get vaccinated. Matt.
Thank you, Dr. Tucker. There are plenty of opportunities to get vaccinated and boosted around the state, and to schedule an appointment for a location near you at Northern Light Health, we encourage you to go to our website at covid.northernlighthealth.org. Also, Northern Light Home Care and Hospice will be holding a booster blitz clinic at Pier 1 in South Portland again this week. It will be offering Pfizer, Moderna, and Johnson & Johnson vaccines for anyone 5 years of age and up needing a first, second, or booster shot. No appointment is needed for that location. And the scheduled clinics for that week at Pier 1 are Thursday, January 13th from 1 to 7 p.m. and Friday, January 14th from 1 to 7 p.m. And each week they assess availability and put out additional schedules. So please stay tuned for that. And I also want to address some mixed messages that are out there about the safety of vaccines. The clinical trials, both safety and efficacy for each of the current vaccines, have involved tens of thousands of individuals covering a wide array of ages, ethnicities, and cultures. These are standard clinical trial numbers, and in many cases have exceeded the initial study numbers for many of the commonly used medications that we have today. Over the past year in the US alone, more than 200 million individuals have each received these vaccines, with very few reported serious events occurring. Contrast that to the number of people that are sick, hospitalized, or dying from COVID-19. For vaccines, serious, even not so serious events are typically picked up within 1 million doses administered. Even after more than 500 million doses of vaccines administered against COVID-19, we have not seen any large-scale reports of any major side effects or significant numbers of serious events associated with these vaccines. And now at this time, I'll turn it over to Paul to review different classifications of staffing during COVID-19.
Thanks, Matt. As many of you have already reported, the US CDC has issued new return to work guidance for healthcare workers infected with COVID-19. Northern Light Health has continued to maintain the guidelines that the state and federal CDC, with guidance of our own clinical experts throughout this pandemic. The announced isolation and quarantine guidelines, we've updated our return to work policy to allow staff to meet specific requirements, screening, and testing criteria to ensure the ability to return to work safely. Our return to work guidelines for employees infected with COVID-19 returning to work is based on the CDC guidance and is similarly broken into 3 categories: conventional staffing, contingency staffing, and crisis staffing. Under conventional staffing circumstances, a worker infected with COVID-19 would need to quarantine for 10 to 7 days with a negative test if they're asymptomatic. Under contingency staffing, the quarantine period would be 5 days with a negative test if asymptomatic or mildly symptomatic with improving conditions. This is stricter than the CDC guidance and which does not require a negative test. Under crisis staffing, there would be no work restrictions with prioritization given to asymptomatic or mildly symptomatic employees. And this is a measure of last resort after other measures have been implemented. At this time, we've not activated crisis staffing in any of our member organizations and did not have COVID-19 positive staff working on site. As of today, we activated contingency staffing at 5 member organizations: Northern Light and Maine Coast, Mayo, CA Dean, Inland, and Sebasticook Valley hospitals. It's our intent to use this flexibility in the smallest increment possible and as one more tool to support patient care under these very challenging conditions. I would like to reiterate that under our contingency staffing policy, no COVID positive employees are working. Community members, again, as Matt and Dr. Ducker have already said, can do their part to help local hospitals by stopping the spread of COVID-19 through practicing hand hygiene, masking, and getting vaccinated or boosted if eligible. Thank you. And with that, we turn over to questions.
All right, thanks, Paul. We'll get started today with WABI. Brittany, you should be able to unmute now.
Thank you very much, Andy and everybody else. My first question will be for Paul Bolin. I would like to get an update on the numbers of staffers that you have out right now. And you just mentioned that you have activated contingency staffing at 5 hospitals. What would the numbers be or the levels be? What would trigger crisis staffing?
So at this point, a number of factors would need to be in place to affect crisis staffing. A combination of the number of patients and the acuity of those patients, in addition to the staff impacted by COVID and out of work due to that. So it would be a complicated assessment. It's not just if we have this number of patients, we're at contingency or therefore crisis in other circumstances. So it is a complicated mix of the patient acuity, patient needs, and staffing. In terms of the absences that we have, we're at, unfortunately, an all-time high number of staff out of work. We have 605 employees who are currently either quarantining, waiting for test results, or who are actively positive for COVID-19. That's up. We have 184 additional COVID positive employees who tested positive and are out of work quarantining just this week. So it's a significant increase from prior weeks, and it's our all-time high number at this time. So that's not something we're working hard to ensure our staff maintain safety both at work as well as outside of work.
Thank you very much. And for, let's see, this will be for Dr. Ducker. We're hearing, or today, the Boston Globe has a headline that Massachusetts is estimated to be about 2 weeks out from the peak of Omicron. And I'm just wondering where we stand, if we are 2 weeks behind Massachusetts, or is there any evidence that's showing how far Maine might be out from the peak of Omicron? Thank you very much.
Predictive models are always based on as much science as we have, and but to a large extent, there's an element of judgment that goes into it. I mean, if you judge what's happened in Maine over the length of the entire pandemic in comparison to Massachusetts, then typically we have followed them 2 to 3 weeks later. So I think that's a very reasonable assumption to make. I would say that that means that we're probably in for a very rocky month, as I mentioned briefly last week. Numbers are very high in all the health systems in Maine, and I would anticipate they'll get higher. And our main kind of public health message is to try and do all we can to keep patients away from the hospital, so that we can deliver the care to those that do end up in the hospital to the highest possible standards, as we always do.
Thanks, Brittany, for your questions. Next up, we have Ross, WMTW. Ross, you should be able to unmute now.
Hi, thank you. My question is for Dr. Ducker. You led off talking about the very high test positivity rate. I'm curious what your thoughts are on the current state of Maine's testing capacity, looking at various booking sites for the different publicly available testing sites around the state of Maine. It can be up to a week out for some areas. What are your thoughts on how robust and the testing apparatus is here in Maine, and what can be done to improve it?
Well, I think we keep an eye on those access metrics too, not just for our own patients. When we contact patients and they're in a different geographical area, we'll try and help them, advise them on where they can get a test that's closer for them. And we're aware of the delays of up to 6 or 7 days in some cases, in some places for testing. So, I think the logical conclusion from that is that it's stretched at the moment, and it isn't at the kind of level that we've come to expect and really need at this time. That leaves many of our citizens, our community members, in a challenging spot when they develop symptoms, because obviously we're advising them to get tested as early as possible to see whether they have viral symptoms from COVID-19 or viral symptoms from another respiratory infection. And the current testing is stretched to allow them to do that, meaning that they may be taking, when they isolate or pending testing, that they may not in fact need to isolate. In terms of where it's going to go, we do know that the state received 250,000 antigen tests, which I believe have been channeled through Walgreens in a kind of drive-in setup. And Walgreens, I trust and hope, will continue to do what they've done as well, which is to ensure that they are adequately staffed to be able to deliver those additional tests to the public in a smooth and as seamless a way. And obviously there's a large network of Walgreens pharmacies across the state serving the majority of our communities quite directly, but hopefully within driving distance for the rest of the communities that we serve.
And can you kind of share a bit of a top-down perspective on why the number of mass testing clinics and even the availability of testing appointments is not as widely available? What's kind of getting in the way of those being as readily available as we might hope?
So I what I say to you about that is kind of similar to what Paul was saying earlier. It's a complex combination of factors. Clearly, we need to be staffing whatever testing setting we're talking about, whether it's one of ours or another entity, needs to be adequately staffed. And as you've heard, staffing is an issue, but the staff get sick too. The second thing is that we need the tests to be able to administer. If you have a clinic that's fully staffed with 3 testers and ready to go, and you have a limited number of tests, it's it becomes a bit of a wash at that point. And then we kind of tie in the demand side, which the demand side is being fueled by 2 main things. One is there's a lot of people who are sick out there, and the second thing is we are telling the public that if you develop upper respiratory symptoms, you need to get tested to see whether how long for you need to isolate to avoid spreading COVID, particularly to other community members.
All right, thanks, Ross, for your questions. Next up, we have Chris, News Center, Maine. Chris, go ahead and ask your question.
Hi, everybody. Thanks for taking the time to answer these questions. My first question I think is probably for Paul. Paul, you talked about kind of the complex combination of factors that go into determining whether a hospital is in contingency status or crisis status. Do you feel that there should be some type of criteria at the state level or at the federal level that helps guide a hospital to make those determinations?
So, that's a great question, Chris. And I think that one of the things you have to remember is because it's such a complex problem to solve, it really is a combination of what's the skill mix of the staff that are available to work and provide care. What's the critical nature of the patients in need in the community, both in the hospital now, as well as waiting in the region to come to that facility. So, imposing legislation or other metrics that are well intended, but not as focused on the issue at hand, really would not be a help. In fact, it might limit the good judgment of clinicians at the bedside, physicians, nurses, and others to make good, safe decisions for patients. So I think the guidance that we've been provided by the CDC rather, is a framework for hospitals and healthcare providers to follow, but it does give them their own expertise and judgment to apply to their local organization to meet those patient needs. So I think that's the best combination, the guidance that we have and the expertise that we have combined to provide a mechanism to identify when, if at all, we'd need to go to that level of staffing.
Okay, thanks for explaining that. And then the second question is either for Dr. Ducker or Dr. Marston. I mean, either one of you, I'd be curious to hear your thoughts on this. We have these two definitions out here that of fully vaccinated and also the concept of breakthrough cases. So much has changed since we have developed these definitions. I understand that when it comes to fully vaccinated, that's a federal, like a US CDC definition. So I'm wondering on that front, do we expect that eventually boosters are going to be included in that definition of fully vaccinated? And I think the other part of it, the breakthrough cases, I notice a lot when Northern Light publishes its hospitalization graphics. Many of the people who are in the hospital, maybe not necessarily in the ICU, but those who are in the hospital who have tested positive for COVID, generally, the majority of them who are vaccinated tend to be over the age of 60. Now, when I look at that, that makes me think, well, these are people who got their shots a year ago, basically today, those people who are in their 60s, 70s, and 80s when we were in that tiered system. Should we be rethinking breakthrough cases to, based on the time at which somebody got their shots, their initial shots, knowing that the immunity wanes over time? So sorry, I know that's kind of an involved question, but yeah, definition of fully vaccinated and maybe do we need to rethink breakthrough cases to summarize? Thank you.
Thanks, Chris. And you're right. The definition is maintained at the federal CDC level of who is considered fully vaccinated. And at this time, that has not changed. Although, as we've seen with the recent guideline changes related to exposure, clinically speaking, there are some significant differences between whether somebody is boosted or not in terms of level of risk. And so I would not be surprised if the definition of fully vaccinated changes at some point in the future. And we will closely follow that as well. However, what I will say clinically right now is that the need for boosters is here. And we have seen that for those that are more than 5 months out from vaccination, there is a clear correlation between the number of individuals that experience breakthrough cases and the time from their vaccination. So the breakthrough cases that we are seeing are predominantly in those that are farther out from their primary vaccination series, and those that are boosted do have a protective effect against breakthrough illness with COVID-19. And in the data that got the vaccines approved, and Pfizer reported this out as well, Pfizer vaccine is 75% effective at preventing symptomatic illness with COVID-19. What that means is that there's still 25% of individuals that may experience breakthrough cases. So it's not impossible to suspect that you will still see individuals that have been boosted that may present with breakthrough cases, but it's even far more effective at preventing severe illness and hospitalization. And like we've talked about here today, that is what is impacting hospital bed capacity and flooding the hospitals with those that are COVID positive. And COVID vaccines are highly protective against severe illness. and that effectively gets patients out of the hospital, staying home, able to care for themselves, and preserves our ability to care for patients overall.
All right, thanks, Chris, for your questions. Now we'll go to Portland Press Herald. Joe, you should be able to unmute now.
Hi, thanks for taking our questions today. I was wondering about if you could, I'm not sure who would be best to address this, but if you could kind of compare and contrast the severity of the patients that you're seeing now in Omicron versus maybe even just a month or two ago. When looking at the data, ICU utilization appears to be pretty flat statewide over the last couple weeks or so. And how is that impacting things?
So I'll take that first go at that for you, Joe. We know from published data from South Africa and Europe, but also emerging data from the United States, that the severity of illness with Omicron appears to be less than it was with Delta, which is obviously encouraging. The reason that that hasn't had the knock-on effect in hospitalizations is because it is so infectious that it is infecting the vast majority of those who are either unvaccinated or may have gone more than 6 to 8 months beyond the initial vaccination shot. And so it's a numbers game. If the number of members of our community are getting infected is overwhelming, it's inevitable that a proportion of those will end up in the hospital. And so that's what's happening. Your questions about ICU rate, if you look at the rate of ICU admission over the course of the entire pandemic, both across the United States and in Maine, the proportion of patients who end up in the ICU has consistently dropped since the first surge. And that reflects a number of things, but it basically reflects the fact that we're much more experienced with this illness. We kind of intervene earlier, we have some good treatments available, and we're able to avoid particularly intubation and ventilation at a much more effective rate than we ever were before. Matt, do you have anything to add to that?
I think you're spot on, Dr. Ducker, and we have more treatment options up front from hospitalization than we had in the past when ICU admissions were at their all-time high. So I think that's an important consideration. One thing that I'll add, as I'm sure many of you are aware, is that supply of COVID treatments still remains challenged. 2 of the 3 available monoclonal antibodies are not effective against Omicron. That leaves 1. So all organizations are working hard to leverage all available treatment options to keep high-risk patients out of the hospital. So it's great that we have these treatment options available, but the best thing to rely on and the most reliable thing we've seen all along, again, is vaccination. Because if we can prevent severe illness up front, that means that we're not having to use those scarce resources as often. It also means that people are less likely to land in the hospital overall.
Okay, thanks. My follow-up question is just simply better treatments aside and all those factors aside that you just mentioned. Are you noticing, or are the clinicians noticing that patients are coming to the hospital with less severe conditions, or not necessarily yet? Thanks.
Could you just clarify that for me, Joe? I think I know what you're asking. Could you just ask that again?
Yeah, so I mean, there's been a lot of reports that with Omicron being less severe, and I know maybe we're a few weeks behind other places, so I'm not sure if this has shown up yet, but are the clinicians noticing that the average patient that comes in is less severe infected? I mean, I know the treatments are better, but
Sure.
All that factoring that in, I guess.
Yeah, I understand what you're saying. So, again, what I'd say is that it's a numbers game, and with highly infectious variants out there and large numbers of people getting infected, there's always going to be a proportion that end up in hospital and a proportion who really get severely sick. And so the hospital is at the kind of the top end of the pyramid of cases, if you like, seeing the patients that get sick and very severely sick. And they continue to see patients who are getting sick and very severely sick because, and it's not, how do I say it? As a proportion of the total numbers, it's probably less because this variant causes a less severe illness, but because so many people are infected, the numbers presenting is higher. And so what the hospitals are seeing are the same kind of issues that they've had to face throughout the pandemic. Patients who fall into that group who get a severe infection are getting a severe infection and need our help and assistance and treatment. I hope that answers your question.
Right, Joe, thank you for those questions. Next we have David Marino, Bangor Daily News. David, you should be able to unmute now.
Thanks. This is a question for either Dr. Ducker or Dr. Marston. A lot of school officials tell me that COVID-19 transmission that is occurring among students isn't really occurring in the classroom. It's occurring outside of school. Do you feel that that appears to be the case, including with this Omicron surge? And is it always discernible how COVID transmission occurs, even with contact tracing in cases like this?
Yeah, I could take a stab at that too. So children in school, it's hard to say whether or not that transmission occurred in school versus occurring at home. But what I can say is that the measures that are in place at many of the schools surrounding the need to wear masks, the need to distance, and the attention that teachers and school staff have provided to making sure that children are staying safe in those settings, that lends itself to the same preventative measures that we stress in the community that limits the risk of transmission. So I think schools are doing what they can to keep our children safe, and it's a monitored environment, which is much different than an environment at home where individuals typically are not masked and around each other, and the potential for spread is there. So individuals certainly can test positive out in the community and bring that into a school setting. Things like pooled testing, rapid testing that many schools are offering, and follow up to that testing, promoting vaccinations and trying to get more children vaccinated. All those things keep our schools safer, and that lends itself to allowing our children to stay in school and stay healthy, and a better learning environment to be able to continue offering those things for our kids.
And in terms of the exposure, with such widespread community spread going on, you've seen our positivity rate, the exposure for any citizen in Maine in the community is high. And without really detailed contact tracing, it really becomes very challenging to decide, oh, this exposure happened at this particular setting. And so, the school administrators are faced with a challenging spot. I mean, I think they just need to focus on what they've been focused on, which is trying to keep the kids safe, and anyone who is sick needs to be off school and adequately isolated until they're no longer a risk to anyone else, either in their own families or in the school.
Thanks. It's kind of a follow-up. Only 33% of 5 to 11-year-olds in Maine are fully vaccinated. It's even lower in many counties, only 11% in Piscataquis County, which is I find pretty surprising. Given its availability for a few months now for kids in that age group, do you feel that number is too low, statewide? And could a significant unvaccinated population in that age group make preventing transmission in schools more difficult?
Yeah, so to speak to the first thing, yes, I do think it's too low, right? The more we can get our children vaccinated, the safer the environment our children are in. And severity of illness has shown to be less in children, but we've also seen record numbers of children hospitalized with Omicron as compared to prior variants across the country. So children are not immune to becoming sick with COVID-19, and they're certainly not immune to transmitting COVID-19 onto others that are at higher risk of severe illness and landing in the hospital. So vaccinating our children is really critical to making sure that we are controlling this pandemic and keeping those that are vulnerable safe. The vaccines are still highly safe and effective in children. And even though 33%, as you mentioned, have been vaccinated, we have not seen high rates of adverse reactions at all in that age group. And so I would encourage anyone that has not had their child vaccinated to strongly consider doing so and try to keep yourselves and your communities safe. And Northern Light Health has partnered with many of the school districts around the state to offer up our services to assist with vaccination clinics. And we've offered targeted vaccine clinics for children to try to add convenience and make sure that people can access those vaccines for their children that are eligible. It will continue to monitor that and do so and respond and try to meet the needs of the community there, because it is critically important that we try to cover as much of our population as we possibly can.
Yeah, I mean, I agree with Matt. Yeah, that vaccination rate is far from ideal. I mean, as is the case with adults. I mean, the adult rate is about 64% now, isn't it, in Maine? And that's far from ideal too. I mean, so we need to continue to do the messaging that we've done, which is that for those who are hesitant, we need to be able to listen to their fears and concerns and address those. So that they feel that they've got the information they need to make great decisions for both themselves and their children. And you know, we've been doing that for a long time. We'll continue to do that. Our doors are open in terms of offering vaccines, but our doors are also often open in terms of giving advice and making all assistance that we can to families and children to make the decisions that are right for them.
All right. Thanks, David, for your questions. Last but certainly not least, we'll finish up with Patty White, Maine Public. Patty, you should be able to ask your question now.
Thanks very much. My first question is for Paul. I apologize if you said this before, but can you tell us which 5 hospitals you had to move to contingency staffing for, and how close are you to needing to do that at other hospitals?
Sure. So let me just go back to my list here. I want to make sure I give you the right information. Okay, and so the list of hospitals that we have that are currently on contingency staffing, those 5 hospitals, we have Maine Coast Hospital, Mayo Hospital, C.A. Dean, Inland, and Sebasticook Valley Hospitals. And the second part of your question?
How close are you to needing to move to the contingency at other hospitals?
I think it truly is at this point, day by day, looking at the current needs and the current impacts on staff. As I mentioned earlier, we had 184 employees test positive for COVID just this week. And so that's, you know, consistent with the type of spread we're seeing throughout the community. 8 of those were, we believe, from work exposures, the remainder from community exposures. And so our communities continue to be, you know, you know, an area of concern from a safety point of view for our workforce. Absolutely.
Okay, thanks. And this next question is for Matt. Matt, can you just tell us a little bit more about what your supply is like for the treatment sotrovimab? How short are you for what you need, and what kind of decisions is that forcing you to make?
Yeah, I can speak to that. So our health system had been providing north of 250 monoclonal antibody doses per week out of our monoclonal antibody infusion clinics. To put that in perspective, the state has received close to that amount for the state in the most recent shipment, because before we were able to spread that across multiple different monoclonal antibody types, right? So now 1/3 or the amount that's used for that monoclonal antibody treatment that was spread out across 3 is now having to be subdivided and used around the state. So what we are doing at Northern Light Health is making sure that we're offering up not just monoclonal antibodies, but other treatment options to our patients as well, to try to place them with what's available and what they're eligible to receive, to try to cast that net wide and make sure that we're accommodating as many patients as we can. Another treatment option that has presented itself from some studies that are out there is remdesivir, which is an antiviral medication we've used in the hospital setting for some time now to treat those that are acutely ill with COVID-19. That can also be infused in an outpatient setting now, with recent evidence showing that it has similar effectiveness to the monoclonal antibodies, and it's given as an infusion once a day for 3 days versus a one-time infusion like the monoclonal antibodies. So it does have some differences associated with it. But again, like I said, we're committed to offering treatment to as many as we can that are safe and effective, and making sure that we're using all available options to care for our patients. So the monoclonal antibodies, while they are in a much shorter supply now, they are not the only option that's out there to care for our patients. And we're making sure that we're using whatever we can to be able to provide that. And as a follow-up question in the chat too, yes, remdesivir at this time is not in short supply. So it does provide a viable option that we can use in its place.
All right. Thanks, Patty, for your questions, and thanks, Chris, for your follow-up. It looks like we've gotten to everybody, so we'll plan to end there for today. Thanks all for attending and helping us to spread the word and get out this important information about COVID-19. As I mentioned earlier, we won't have a high-quality file today of the video to share with you, but we do have a backup recording. If you need it, just let us know. I think with that, we'll end here, and we'll see you all again next week. Thanks.
Thanks, everyone.
Thank you.
Bye-bye.